Our next speaker is Colonel Lamone Collins. He's the Chief of Vaccine Safety and Evaluation Section at the Defense Health Agency.
First of all, I want to thank the organizers of this symposium. I think it's an excellent opportunity to have these collaborations. And so I personally want to thank Dr. Gobot-Mansky and Dr. Jones for inviting me here. So today I want to talk about something that I think touches all of us. We've rightly shown the rarity of the events of immune dysregulation. But what I'd like to talk about today is something that we all have within our lifetime experience with, and that's immunizations. And so I think in regards to connecting to at least the topic that we want to elaborate on, that you'll have some connection to it. The area of vaccines and autoimmunity, that's actually a story that has gone on, particularly with the onset of immunizations. And there have been a number of studies looking at the issues of vaccines and the connection with autoimmune disease. And particularly, the Institute of Medicine has done some exhaustive investigations looking at particular autoimmune phenomena, and especially with diabetes mellitus, a lot of literature and again, investigation, especially in the pediatric literature, has not been able to show a connection. For some of you who are familiar with the French experience with multiple sclerosis, there was a huge hue and cry of the connection, or at least the alleged connection of hepatitis B vaccine because of the concern with the association with multiple sclerosis. They actually discontinued the program in France, and but really without any scientific investigation. And I think if we take a theme, one of the themes from this symposium, and it's really connecting the dots with the sciences and let the scientists make those connections before we use fear, and that was unfortunately the case in the French experience, of leading to mandates. And that is one of the things that we want to try to make sure we don't have the experience here. So, so why all the pushback with vaccines, and particularly with the topic of immune dysregulation? Why? As an immunologist, to me, it would be something that would be, potentially a connection and something that we would want to look at. But, part of it is because of our success with vaccines. And as I said, all of you have had some experience in your lifetime with the receipt of vaccines. And it's because we've been very successful. It's been a robust program that I think most of the public health activities that we use has been found to be very successful. I have an ongoing argument with my brother, who's a cardiologist, who thinks that if he sticks anything into a artery, that he's done the greatest thing in the world. And I always have to remind him that we've done more within this country with vaccines, to protect our country and our public. And so, that's a good thing. But I think the balance of the message is that there's always a possibility for adverse reactions to occur. And so that doesn't mean that we stop a successful program. We just do what we always do as credible scientists. We look at it, we investigate it. And sometimes what you will find is that message gets mixed, okay? So even though you inquire about an adverse reaction, particularly in the area of immune dysregulation, that doesn't mean that you stop the program overall, Okay, and so that is been part of the dilemma that we've had when we tried to investigate, credible or the possibility of immune dysregulations with the association with vaccines. And the other thing I think we have to always take in consideration, and that has been repeated over and over during this symposium, is that these events are rare. They're very rare. And so trying in the past to substantiate that has been difficult, and especially in the area of vaccine research. And we give here a couple of examples here where we've seen in that temporal association that there have been credible connections from an immune mechanism, and the GBS with the swine flu in 1976, or ITP and MMR. And more recently, particularly with the experience in the Department of Defense, the smallpox vaccination program and the occurrence of mild pericarditis. Okay, those clearly have some immune connection. It's putting the dots together to make sure we make that determination. And unfortunately, what the tools that we've used in the past to try to make that connections have been primary epidemiologic studies, which, because of the rarity of these conditions, really don't connect. And so we have to try to get past that. And so some of the proposed mechanism, particularly when we talk about molecular mimicry, has not been substantiated, at least with some of the tools that we have now. So this is kind of the background that we're facing right now. So where does that leave us now? And that leads us to actually what a lot of folks have been talking about this morning, and that's the study of vaccine adverse events, but using the immunogenomics and a system biology approach. And so what you will find now moving forward is that as we develop new vaccines and as we look at adverse events, that we move to a point of looking at let's look at a different way of investigating that adverse event. Okay, so one of the questions that always gets thrown at me is, well, why should the DoD embrace adversomics, which is the terminology, adversomics? Okay, so why is that important to the DoD? Well, first of all, just particularly within the DoD, we give a lot of vaccines. Okay, and most of you who wore the uniform know that unlike our civilian colleagues, we get a number of vaccines. I can remember as a second lieutenant in Charlotte, North Carolina, lining up with 100 other guys getting about 10 vaccines. Okay, so unlike the rest of our community, we get a lot of vaccines. So we're a major proponent of having a good vaccination plan within the United States. The DoD has a long history of being at the forefront of developing new vaccines, and that continues on now. And perhaps despite what you may hear, the DoD is part of developing those new vaccines, the Zika virus vaccine. The DoD is playing a role in there. Any post-surveillance study, anytime a vaccine is developed, the FDA mandates that you have a post-surveillance program. And we're responsible, particularly for those vaccines that have military relevance, that there's ongoing studies that play a part in there. And one of the things that people probably don't also realize is that, and especially our organization, is responsible for adverse event recognition. And anytime within this country, any U.S. licensed vaccine, if there is even a suspicion of an adverse event, that there's a requirement to submit a VAERS adverse reaction report. Our organization, it monitors and investigates each and every one of those for the DoD. And so you can see that there's a large investment within the DoD to making sure that we have vaccine safety and assure vaccine safety for our community. And then, and I think the no-brainer is that we have a large, diverse population, and we are sending our service members all over the world. And similar to the young second lieutenant in Charlotte, North Carolina, who got the 10 vaccines, we're doing that every day. Okay. And so it's important for us, for our service members as well as their beneficiaries, for us to ensure that they have safe vaccines. Most of the folks who receive vaccines are healthy. Okay. And so it is an obligation for us, and we have an ongoing system that is responsible for making sure that that is the case. So, what are the advantages of Eversol? Well, it's a departure from the old mantra of making a vaccine. Okay, I mean the current mantra was actually from Pasteur. Okay, you isolate an organism, usually it was a bacterial or viral organism, you inactivate it and then you inject it. Okay. But we, as immunologists, we know that there are a lot of other factors that are mitigating. The efficacy, how do we respond? Why are we finding that we're needing to give multiple doses of vaccines that back in, my day as a child of the 50s, we had lifelong protection? Why are we repeating that? Well, we know that there are multiple factors. There are gender differences just by itself, age, a number of factors that contributed to this. So as my old mentor was said to me on multiple occasions, we have to get away from the one-size-fits-all plan of action. Okay. And we have to take in consideration that, particularly when we're dealing with organisms that are a little bit more complicated and hypervariable, that has to be taken in consideration. And so, and when you add to those things that Dr. Fleischer mentioned in regards to the immunodiagnostics, we have new immunodiagnostics, and so those things, so we have to look now when we investigate, adverse events following immunizations, are we really doing a credible job of making sure that that's happened? And that'll be beneficial in particular in regards to how we develop new vaccines, okay? We must take all those things in consideration, even in the development of the newer vaccines. And so the Eversomics, those considerations must be addressed. Now, my only other commercial here is talking about who we are, and that's the Immunization Healthcare branch. We're part of the Defense Health Agency, but similar to a lot of things over the past several years, we've morphed. And we've actually come from two organizations, the old MilVax, or Military Vaccine Agency, which was primarily responsible for policies within the DoD for the vaccine implementations. And then the Vaccine Healthcare Center Network, which was founded by Colonel retired Renata Engler, who looked and focused basically on the experience of care. We looked specifically at adverse events, and what can we learn from the adverse events that resulted from, again, giving our service members vaccinations. So we've tried to redirect what our mission is, taking considerations of both how can we make it, how can it fit into the policy, and what are the lessons learned, but specifically, how can we help our investigators when they're looking at developing new vaccines, what are the challenges from that, and what are we learning from our service members or any of our patients who have those adverse events? How can we best formulate research studies to address those issues? And so it has changed how we look at it. Are there credible biomarkers that we can look at? How can we look at treatment regimens or actually diagnostic regimens on how to best approach that? So looking at biomarkers, has become a greater issue, particularly in regards to the evaluation of adverse events. And so, what are the things that we're doing? And just a couple of things to talk about our research efforts. The metabiotics, we have an investigative study. This is just a collection of metabolic products and looking at how they're connected, what's the direction with identified service members who have adverse events. We have a large experience, particularly here within Walter Reed, with the mild pericarditis issue, a number of serologic specimens that we have used, trying to address what's the importance of some of these cardiac autoantibodies that we're seeing associated with these individuals, and trying to make the connection of certain, again, the activities, the pathogenesis with the high sensitivity troponins. So is that important, or how important that is? And I think the other thing too is that we've tried to mention here is the collaborations. And so one of the things that we've tried to do is partner with a number of collaborators who have expertise, particularly in the area of immune dysregulation. And that's one of the things you'll see here with our experience with the anthrax vaccine and collaborating with the Oklahoma Medical Research that has some specific expertise in immune dysregulation. And so those are some of the things. So this area is, again, it's in its infancy, to be honest with you. It's in its infancy, and so there's still a number of things that we are still learning about, but I tried to list some of the references and some of the investigators that are talking about this. But this is the new area of vaccines and adverse events. I look forward to any potential collaboration. We also have an arm where we sponsor credible research activities, obviously with vaccine specific themes, but this is the area that I have the opportunity to fund researchers in. Okay, and other than that, thank you very much for your attention.
Thank you, sir. Our next speaker is Lieutenant Colonel Mary Hinkle. She's the Deputy Director of MRSN at the Walter Reed Army Institute of Research.
Okay. Good morning, everyone. I actually go by Kate, so I'm Lieutenant Colonel Kate Hinkle. I'm an adult infectious disease doctor by training, but fortunately 2 years ago I had the opportunity to kind of make the jump into the research world, or more accurately for us anyway, performance improvement. And to take over as the Deputy Director for the MRSN, which is the Multi-Drug Resistant Organism Repository and Surveillance Network based out of the Walter Reed Army Institute of Research just down the street. And then over time, this network grew into what we have actually called the ARMOR program. So it's the Antimicrobial Resistance Monitoring and Research Program. So based on our title, you can see what I'm going to be talking about today. It's kind of in contrast to some other topics we've been talking about this morning, all bacteria, although I do think we have some areas of opportunity for collaboration. In particular, I included one example from a couple of years ago where I first actually came to be familiar with Dr. Jones pretty much within a month after arriving to the National Capital Region. So we'll go through quickly, just as an example of some of the interactions that we've had before. So this is just what I'm going to go over about our program, a very small amount about the history of the program, as well as some of the offerings that we have. And then again, just a quick example of the prior work that we've done with the Walter Reed National Military Medical Center. The MRSN was actually initially launched in 2009, and initially was started as really an Army-only infection control and quality improvement initiative. And the reason why it was set up was really in response to the alarming increase in antibiotic-resistant wound infections in particular that we were seeing in combat-injured service members coming back, mainly from Iraq and Afghanistan. And the main mission and the main goal was to really ensure safe and high-quality medical care within the military healthcare system by providing better surveillance of these types of antibiotic-resistant bacteria that were present within our healthcare system. And over time, as the repository function kind of took hold, and we were able to build collaborations with other agencies. Again, we developed into what we call the ARMOR program, and really what's significant about that and kind of different about this program is the information sharing and feedback loops that we have within, not just within the Army, but really completely tri-service within the Navy and Air Force hospitals as well, mainly with the healthcare providers and infection control staff, but really have been building the network beyond that, and we actually do have collaborations ongoing right now with the VA, with NIH, and with multiple civilian healthcare facilities. So again, our main mission is to collect and store and characterize these very multi-drug resistant bacteria. But what is unique about our repository as well is we actually do collect a significant amount of clinical and demographic data about the patients that from whom the multi-drug resistant organisms have been isolated. And that's really, we do this as a means of informing infection control and policy, and also empiric selection of antibiotics, mainly again within our healthcare system. So the submitting facilities that we started out with were really just the Army facilities worldwide, but early on, I think very quickly, a lot of the other Navy and Air Force facilities realized the benefit of submitting their isolates to us. And so we always had voluntary involvement from the Navy and Air Force facilities. However, just this past July, we are now officially tri-service with an MOU signed by all of the service surgeon generals. So we will officially be accepting multi-drug resistant organism isolates from all DoD MTFs. And then mainly, the trick about a repository, right, is that it's not very helpful if kind of all the information goes in, but no information comes back out, right? So the trick is to be able to turn around that information to make it useful for the healthcare facilities and to better patient care. And so what we're continuously improving is our feedback back to the military healthcare systems or to our civilian facilities. As I mentioned, we have several facilities, especially throughout the United States, that have sent us isolates mainly with reasons of concern for infection control and patient care. So it's one of our main goals to continue to provide this feedback to whatever the treatment facilities are, as well as to military commanders and policymakers. And as kind of part of that last comment that I made about policymakers, we actually have been very much involved in what some of you may be familiar with as the National Action Plan for Combating Antibiotic-Resistant Bacteria. This is something that's been, this is not by any means a healthcare problem that is unique to the United States. It's actually probably, arguably, more of a problem even outside the United States, and this is something that's been recognized by the White House. The National Action Plan was actually published last fall, but with the MRSN specifically being mentioned in this plan as being key, basically, for the DoD's part in responding to this crisis. So our target organisms that we collect are listed here. We kind of they're affectionately called the escape pathogens, and these are the types of pathogens, especially in healthcare settings, that are most likely to develop resistance to multiple antibiotics. And so, if you think about it just quickly, these are the bugs that we care about taking care of patients, because these are the things that are most likely going to see in our patients that are hospitalized, and over time. The enemy always changes, right? The enemy always adapts and overcomes. So there has been very large-scale concern globally about about carbapenem-resistant gram-negative bacteria. Carbapenems being one of our broadest and kind of last-line antibiotics that we have to treat gram-negative infections, as well as Clostridium difficile, which can be a very significant problem both for immunocompetent and non-immunocompetent patients. However, more recently, we've kind of taken on an additional role, and you'll see it mainly as a result of our sequencing ability. So that we're not just focusing on these pathogens, although these by far make up the vast bulk of our repository. We're actually taking on requests for basically just other clinically relevant organisms by request from specific MTFs. So mainly these kind of fall into two general types of requests. One, problematic species, so species that the automatic machines that we use in most of our clinical labs either can't identify or they get conflicting results. So kind of, some more difficult bacteria, for instance. These are just examples of, within the last 6 months, some bacteria that we've had to identify for different MTFs, including Moraxella, non-tuberculous mycobacteria, and microbacterium. But more and more frequently, we see involvement in what we call kind of our outbreak or transmission investigations. So this is basically where one of the treatment facilities calls us up and said, hey, we've seen kind of a rash of these particular organisms, or maybe that have this particular antibiotic susceptibility program or profile, and we're worried that that we're seeing transmission within our facility. And so what we've been able to do is use the whole genome sequencing capacity that we have, that I'll detail in a minute here, to help prove or disprove these concerns. And in particular, some of the organisms that we've helped out with include methicillin-susceptible Staph aureus, so not just methicillin-resistant Staph aureus, Strep pyogenes, and H. flu. So we have kind of three main branches at the Walter Reed Army Institute of Research. Our clinical microbiology lab is really not much different than any other clinical microbiology lab in any of the hospitals, except that we have more of the stuff. We have more of the instruments and more of the people focused on this idea. So this lab is basically just focused on receiving all of these very drug-resistant isolates from around the world, processing them, creating backup samples, storing them off-site, and then keeping track of that main repository. Their main job is species-level identification and susceptibility testing, and we actually have, as I mentioned, we have all three of the commercially available platforms that are most commonly used in US hospitals, the Phoenix, the Vitek, and the Microscan. And the reason why we did that is because, believe it or not, there is actually no standard platform, at least within the military healthcare system. So all the different hospitals may be using different susceptibility testing platforms. And it's difficult to compare apples and oranges. It kind of makes sense. So when we're feeding back information to these hospitals, if they say, well, we tested it on our Phoenix, and they said, well, we don't have a Phoenix, we have a Vitek. We want to be able to speak the same language. And then mass spectrometry, which is kind of becoming more of an up-and-coming means of quick and accurate identification of species, as well as broth microdilution and e-tests, and those are more specific and definable means of developing or of detecting antibiotic susceptibility. And this lab is actually certified by the College of American Pathologists, which is actually, again, a very typical certifying laboratory service for clinical labs, but not necessarily for research labs. So as far as our molecular microbiology lab, so again, initially with the beginning of this project, we were really focusing on just the use of PCR assays. So these are specific assays that, as I listed out here, will detect known mechanisms of antibiotic resistance. But that's kind of the limitation in that they're fantastic in that they're rapid and they're very sensitive, but you can only test for what you know. So you can't necessarily find easily new methods or new mechanisms of resistance. So what our molecular microbiology lab has really morphed into over the last 18 to 24 months is a high throughput sequencing lab, again, dedicated solely to research on bacteria, unlike the other sequencing capacities that we heard about this morning, but using very similar technology. So also using benchtop sequencers, MySeq and NextSeq. We have 2 right now. We'll be adding 2 more of each of them, as well as a long-read sequencer. So this machine is actually especially helpful in trying to define the genome of very drug-resistant bacteria that are carrying multiple drug resistance genes on some transmissible pieces of DNA called plasmid. So basically the ability to share not just your antibiotic resistance with the daughter cells, but also pass it on to neighboring bacteria. And then in addition, we also have some automated liquid handlers, or basically, robots. I think actually one of the previous presenters actually showed a picture of the exact same instrument that we have. And this basically just allows for, instead of, individual, pipetting, it allows for really kind of significant improvement in throughput. Of course, with sequencing, as was mentioned before, the ability to perform whole genome sequencing is very useful, but you have to be able to store and analyze all of that data. And that's actually something that, believe it or not, has been probably one of our biggest challenges, especially behind DoD firewall. So just the fact that being able to just buy off the over-the-counter kind of software for analyzing sequencing information doesn't really work in our system. So we've had to kind of build our own. And so we've created an automated software pipeline for the analysis of all of our DNA sequencing data. And the automated products that are generated include 16S species confirmation. So basically gold standard of defining what the species of the bacteria is, which sometimes can be difficult, believe it or not. As well as specific antimicrobial resistance genes, as well and virulence gene content, multi-locus sequence type derivation, plasmid finders, and relatedness and phylogeny. And this is kind of the area that we find ourselves doing most, I'd say, the most interesting work recently. And again, that's in these requests from military treatment facilities to look at strain comparison to detect possible outbreaks. So just some of our quick accomplishments that we've had so far, and we have such high throughput that these slides that I put together a couple of weeks ago are already outdated. But we have generated over 3,000 genomes on the MySeq and NextSeq platforms. Now well over actually 50 genomes on the long read sequencer. As well as several hundred genomes that we've submitted to the to GenBank, basically to have available for wider communication within the scientific community. And kind of one of the things we've perfected over the last year that we're really most proud of is the fact that we have a 48-hour turnaround time from the time that we have receipt of a multi-drug resistant organism in our lab to the time that we can sequence it and at least give a quick verbal report back to the hospital. Yes, you have the same isolate in 6 different patients, or no, you don't. So, i.e., yes, you have an outbreak, or no, you don't. And then the other thing that we ran up against pretty early on, in addition to just crunching all of the sequencing data, we have to have a place to be able to store all of these results. And as anyone who's familiar with kind of the off-the-shelf Excel and Access database, you can max those out pretty quickly when you're talking about millions of data points. So we've built our own. So this is what we refer to as the ARMOR database. This is actually a work in progress. It's storing all of the information that we have on all of these very drug-resistant bacteria, including the clinical data that accompanies them, which is really something unusual. So it includes the identification and susceptibility results, as well as the PCR results and all of the sequencing data. And just some of the quick stats, but again, from January of earlier this year, these numbers are already well surpassed at this point. So as far as our main outputs, I think you can probably guess by now that we spend the majority of our time really kind of just processing and performing what we call kind of our aggregate reports. So these are basically reports back to the facilities about what types of bacteria that they're seeing, and including kind of a full breakdown of their antibiotic susceptibility profiles and their sequencing information, and then specific reports back to hospitals and providers and infection control if there's concerns about outbreaks. But we do actually take some time to do some research and do some publications. And actually, just last week, 2 of our researchers actually had a collaborative paper that was published with the NIH, specifically about a gene called MCR1, which encodes colistin resistance, and colistin being an antibiotic to very drug-resistant gram-negative infections that is now kind of concerningly been found on plasmids, which means that it's far more transmissible than it was before. So this is just a quick description of a question, I would say, that we had from Dr. Jones back almost 2 years now, I think, ma'am. And it was right after I'd come to the MRSN and was really kind of still trying to understand what we could do, and really before our sequencing capacity was really, kind of up and going at full speed. But I think I looked back when once she invited me to the symposium, just kind of looked back. One, kind of maybe a little bit nostalgic for some of our older data. It looks much shinier and better now. But really, I think just kind of shows some of the individual patient level importance of our work. So basically, the question was about some strep pyogenies, so some group A strep isolates that had been seen in the clinic cohort here, and had some concerning profiles. So the first patient was a 7-year-old girl with refractory HSP despite treatment, and had a positive throat culture for strep pyogenies, which was of concern to have been the trigger for her event. And so this was her isolate. And then there was patient number 2, is another young girl with chronic relapsing osteomyelitis with frequent relapses despite what sounded like very significant treatment that was unfortunately complicated by a lot of side effects. And she had recurrent rapid strep tests that were positive for group A strep. And then you can see her isolate here, as well as some of her family members that were also found to be rapid strep positive. And so there was a couple of concerns. One, with these being isolated right around the same time, was there any relation between the two strains? And then secondly, especially for patient number 2, was there any indication of spread within the household? Because there was even consideration, I think, and Dr. Jones can correct me, but I think there was consideration for not only prophylaxing the patient, but preemptively treating the family members as well. And so you can imagine that, the potential for unneeded antibiotic exposure is never something that we want to undertake. But basically, the long story short, as you can see from the breakdown of the tree here, that we were able to show that not only were these 2 patients' isolates not related to each other, but even the patient number 2, really her strain was not related at all to what was circulating in her siblings. So I think probably saved some unnecessary antibiotic exposure for some family members. So just in summary, the MRSN and ARMOR program is really the only large-scale repository in the DoD of very drug-resistant isolates, and it's mainly derived from all of our patients that are located within the military healthcare system throughout the world. And what I didn't point out before is that this also includes very robust submission process coming back from the combat theaters in Iraq and Afghanistan. So we were getting them literally from the front line, if you think about it that way. Mainly in the past, we focused on escape bacteria and C. difficile and carbapenem-resistant organisms, and those are still by far the majority of our repository. But we've actually, as I've mentioned, started performing some work on bacteria of other clinical significance, really just on request. So now we actually have over 39,000 isolates. That we've been receiving since 2009, as well as all of the relevant demographic and clinical data, which is really something unusual and really not something that many other repositories can claim. We have a CAP-certified clinical lab, as well as the molecular lab with full DNA sequencing and bioinformatics capabilities, and we're able to produce, like I said, specific and aggregate reports about our repository, as well as a 48-hour turnaround time for outbreak support. And then in addition to that, so we have the ARMOR database that I mentioned earlier is actually going to be eventually made into a public-facing website that people will be able to apply for access, to be able to kind of query what is present, at least within the military healthcare system, and to further encourage more collaborations. So I think that is it. I also want to make sure that I recognize the rest of our teams that are actually doing all the work, as has been pointed out before, as well as the fact that I only very recently, within the last month, took over as the director of this program. Really want to point out that all of the work and the development of this program over what is relatively short time period of 6 years was really the brainchild and the work of now retired Colonel Emil Lesho, who many of you probably know, and who we will all miss. So happy to take any questions, or we'll keep moving on with the program. Thank you.